So I've really taken this from a medical school lecture for about third year. And I think that most of you would actually cope very well in third year med school. They all look a bit underwhelmed at that age. So I talk about growth. Really, growth is a really defining characteristic of childhood. We just take it for granted your kids will grow. And a bit of a push, if every family just measured the height and weight of their child on their birthday and plotted it, we would pick up nearly 90% of chronic childhood illness. Because the first thing that happens when your kidneys start to putter out is you stop growing, your height slows down, you cross centiles. We've had a few cases of brain tumours, and if someone had just measured it, they'd have said, oh, with the age of 3, he was on the 50th centile, at the age of 5, he's on the 97th, and then he took off. It's like, well, yeah, he's got growth excess. And people don't measure. So my wife thinks I'm crazy. The two things I've done is resuscitate every single one of my child at birth with high flow oxygen and vitamin K, because I was paranoid about them going blue. And I always measure them on their birthday, and I plot their growth chart. And now that they're teenagers, I don't go to the 4th page, which is all the testicular volumes. But my youngest found it the other day, he's 14, and just said, Dad, 5. You know, I'm the big one. And I just, so the other one is boys will over-call how big they are down below. So if you do like a puberty assessment in general practice, don't believe it. If they think they're a 5, they're probably about a 2. So the parameters that you really don't grow properly, if you think about it, it's quite logical, is you need to have good health, have good genes, good environment, and good nutrition. And if they're all good and you're still not growing, there's something else going on. So we see genetic disorders, any syndrome, or Down syndrome, they're short. Endocrine disorders, they're a bit rarer, but we do see growth hormone deficiency, hypothyroidism. Cartilage or bone disorders. Dwarfs have a cartilage disorder, don't they? They have a receptor defect in their cartilage. They don't respond to it. Then they end up on Game of Thrones. General chronic disease will do it. Severe renal insufficiency in childhood will do it. Congenital problems with your kidneys will make you the shortest of the lot. So the two really short groups that we don't even see are kids with congenital liver problems and kidney problems. They are the shortest of the lot because they've got a massive degree of problem with their nutrition. And the liver ones are usually the shortest, and the med students don't know this, but it's because your liver produces the growth factor IGF-1, which is actually what you grow from. And if your liver's puckered, you don't make IGF-1, so you're very short. So people who have a liver transplant suddenly grow massively. That's because they suddenly make their own local growth factor. So I always say plot them every year and see what happens. There are 3 phases of growth. You've got the infancy, which is very, very rapid growth in the first 2 or 3 years. And I think that's where the Plunker book is absolutely vital. What happens here is important. Stage 2 growth is actually quite slow and linear, and then adolescence you get another spurt. So this here is much more growth hormone dependent. It's fairly linear. This is a multitude of hormones, and this is puberty. There's a guy called Carlberg who actually puts a model up. There's the infant growth, childhood growth, and puberty. It's actually on your overhead, so I won't slides when it comes out, so I won't do too much. If you think about it, babies have huge heads, big eyes, and they're lovely and cute. And by the time teenage years hit, the head's not so big and all their attention's down to about the genitalia. So that's why they're not so cute. And that's called the cephalocaudal gradient of growth. We start off with big heads and shorter limbs, and then we slowly proportionalise out. And that's why the centre of power is actually round about your chin when you're a baby, and it's about your genitalia when you're a teenage boy. And I think that just probably explains the whole of growth in puberty to adolescence. But if you think about it, we do get, baby photos are lovely. They're cute, they've got these big heads. But that's just the stages of growth. And one thing we often measure is, total length is there, but proportions. If you've got a skeletal dysplasia, which mainly affects your arms, you'll actually have a relatively normal trunk, but shorter limbs. And sometimes if you see an adult and you're wondering if they got this, I would ask them, when they get into someone else's car, what do you do? And what I mean is, what do you do to the car seat? Because if you've got short limbs, you'll be shoving the car seat forward and you'll be putting it down or up depending on what you're doing. So if you get in the car after someone who's got a mild form of dwarfism, you'll know because your feet will be jamming up against the wheel, then you're having to put the car seat back. But that's because of the proportionalisation. All right, so what do we generally do? Actually just measuring is the most important. You can get most of it done by a growth, a height, velocity, and a head circumference. Parents' height's very important. General health's good. The parents' height question has to be always remembered that 25% of dad's actually not the biological dad, and which does sometimes come out years down the track when you go, you know, golly, your kid's quite short, dad's 6'4", and then mum says, well, you know, okay, let's not go there any further. And that is the reality of life, is that not all biological parents are the ones looking after them. So then we actually just, if you're happy with this, we screen for chronic disease. We're saying you've got anemia, inflammation, silent rheumatology, renal problems, celiac is always hidden, that always causes problems, and then thyroid hormones. Don't worry about BP3. And chromosome, so short girls and short boys, the karyotype is a very important test. And actually for tall boys and tall girls, if you've got 3 copies of the X chromosome, you are very, very tall. All the women in this room have got 2 copies. Your average height, if you get an extra copy, you get very tall. You tend to be a little bit clumsy and a little bit slow, so you don't tend to be a silver fern. If you've only got 1 copy, which is Turner syndrome, you end up being short, which might have been one of the pictures on the potpourri at the start. And then we look at urine, and then chemistry assessment. What we're meaning that is there are these tubulopathies or kidney problems which cause you to leak protein. And then we look at a bone age. And these are sort of the things we're thinking of long term. Child development record you'd be very familiar with. If they can keep that book, bring it in, and you can see you're growing completely normal to the age of 2 and then everything goes to custard, well, that's different. If you're born growth retarded, premature, 26 weeks, and by 1 year of age you're already short, well, that's a prenatal growth problem. No one can measure properly apart from an endocrinologist, and we always do it on an infantometer. We need 2 people to do it. We need to make sure the head is just about pulled off the neck and the legs are stretched. And what's wrong with this one? Well, we'd never measure the child in a onesie with shoes that aren't touching the bottom, because that's going to be a 3 centimetre difference. Medical students can't do height. If you ask them to do height in a clinical exam and you get the kid and you say make sure your legs are like this, most medical students will then put their other leg even further out just to make sure they're nice and balanced. And they'll never push the spiky hair down. So if you think about it, and you want to have feet together and back up against it. It was one of the exam things for med students a few years ago. They failed it entirely. There's a thing called mid-parental height, that's in your slides, mum and dad's height. And what we do is we add 13 for a boy, we take away 13 for a girl. And that's just to end up putting it on the girls or boys' growth chart. And then there's a range to go with it. That's called the mid-parental height. So it's not actually that complicated. It's essentially, if you're a female child, we take away 13 from that combination divided by 2. If it's male, we add it on. And that's simply because the difference is 6.5 centimetres between the growth charts. So 13 divided by 2 is 6.5. We keep the maths simple for our general paediatric colleagues. You can download these all from the APEG website. Remember I gave you the previous talk? There's an APEG for these boys and girls child records are all there in PDF. You can print them off as much as you like. Very important bit of information because it gives you the first centile. These are the CDC. Also gives you the stages of puberty down the bottom, or menarche for girls. Lets you work out mid-parental height. And of course around the country there's different growth charts coming in and out, but at the moment you can download these, give this to the family and say plot their growth. Height velocity is really important, and that's simply measuring it over 6 to 12 months. But if every parent actually measured every year, you would have a height velocity. And just a little side, I see lots of children with early or late puberty, and this is on the growth chart, so centimetres per year. The average slowly declines through that second phase of growth, and then average increases over puberty. So most people are finished growing when their bones are 17 or so. There is an early bloomer average, and there's a late bloomer average. So this is the Form 1 and 2 girls who tower over the boys who end up being 5'5", and this is the puny little grammar boy who didn't finish growing at university, about 20 years old. So this is the different phases. So if you've got a 12-year-old who's growing at 5 centimetres a year, it does depend. Are they in puberty or not? If they're well in puberty, well, they've got something else going on, because pubertal growth spurts, 10 centimetres a year. If they're pre-pubertal and they're there, that's fine. So that's all there. Same for girls as well. And just showing the 2-year delay between boys and girls. But as I said, the boy's brain doesn't grow up again until about 25, whereas the girls are good by about 15. A little bit on short stature. Short stature is really not a clinical problem. It just needs to be thought about. Is it because the parents are short? Have they got a chronic disease? And look, if they've got some plotted and they've got some height velocities, it wouldn't hurt to say, If you didn't know that, come back in 6 months and I'll replot your growth. And that would be a really useful thing to do. And plot it properly. Again, midterm heights on there. So most of what we see, if you've got a normal height velocity, is just relatively short families or children who have we call it constitutional delay in growth and development. So we're meaning the later bloomers or potentially the early bloomers, which is the advanced ones. And the minute they stop growing or the growth is poor, we know that there's something wrong there. We use a thing called a bone age, which I'll just show you the picture. So essentially what we're doing is we're doing the hand because of the multiple growth plates. And we've got these atlases, and you can download these from the web if you need to. And we're just saying, at what age do these growth plates look like the one in the book? The older you are, the more of these growth plates you get. If you had a 1-year-old baby, there are none of these little growth plates present. And it's quite an easy one. And again, if there's no growth plates present and they're all fused, you're at your final height, irrespective of your age. A little bit about short stature and growth again. I'm just going to flick through these for time. So just a couple of cases. So this is the sort of standard kid we'd see usually in private practice. That if you're lucky, you've got all this growth data, and you can just see that most people don't measure that accurately, so there's a bit of a shifting around. But at the age of 8, he's the shortest at his private school, and mum and dad want to know what's he going to do. So what would I look at? I'd say, well, what's his target height? We worked out that mum and dad aren't that tall. It's about 168. So plus or minus 8 to 10. So they're not destined to have children who are going to be over 6 foot. He's not in puberty, and I'll show you a slide on that. And his bone age is, ignore that bone age, that's the next talk. So his bone age, if he was just short, would be 8, not 5. Sorry. And this is the little orchidometer. This is what we mean by this. We're not saying they're 2 centimetres long. We're meaning they're 2 mils in volume, and there are orchidometers you can get. Most practices should probably have one, but it's not the end of the world. So essentially, before you hit puberty, boys' testes are under 4. They start to get bigger and making testosterone when they're a bit older, and then adult size. When we get kids to examine themselves in total, they actually overestimate this markedly. And that's because we're actually just trying to get the testicular size. And that's why growth in boys is tricky. It's very hard to get down there in boys and examine properly without them causing conniptions. So if the case before we left alone at 8, he didn't have a bone age delay, we'd have said, well, that's his long-term prognosis. He's just a short normal. And there are 2 lots of short normal. There's a group that literally follow the normal growth curve and end up 3rd, or are delayed and short as well and do this. And this is the group that tends to look extremely short, about 16, because they're short parents and they're late in puberty. And they look like they'd never have a growth spurt. So if you had the same kid at the age of 8, again, not in puberty, but much taller parents, well, to be constitutional delayed, his bones, as we looked at them, should have been about 3 years younger, way back here. And normally the history you'd have to get from a mum or a dad is that mum who had a period very late, or a dad who literally said, I didn't start shaving or growing until quite a bit later. And I normally ask the mum and dad, how long have you known each other? And she says, from school days. And I say, what was he like in 5th form? Oh, he was a puny little weed. You know, hardly ever talked to him. Oh, and he's 6'1" now. Oh, well, he didn't grow till he was 21 or 2. You know, that is late bloomer in extreme. So those ones there, we'd expect the final height to be more like up here, and I hopefully got a slide on that. And if you leave them alone, they're still not in puberty because they've got a bone age delay to about here, and then they'll have a growth spurt and catch up. And there, an example of this late bloomer. Bone age is useful. So if you had a 10-year-old boy and he stopped growing since the last visit, this is quite common. Would anyone do anything with this? If the parents come along and they're religiously measuring him on that bit of post by the door, and is there a problem here? He's otherwise completely well. The most common problem here is that this measurement point's wrong. Yeah. So it's not a hooky one. It's saying, look, you've got 4 data points, and then this one's in the straight line. There's something wrong with this data point. Yeah. Mum didn't squish the hair down that year properly or something. But what's interesting, sometimes families, you know how they measure it on the door of the house, on the villa? If they take a photo of that and you translate those numbers into a growth chart, they're incredibly accurate. You know, especially if the dad's an accountant or some paediatrician from the North Shore or something. You know, it's amazing. I once saw a girl with Turner syndrome, and Dad just photocopied it, sent it in, and he saw this lovely growth chart of growing normally until 5 and then just cascading off to about here. And then he's like, oh, I never actually did anything with that growth data. All I did was put it on the wall. I didn't actually put it into a chart. Yeah, that's just a measurement error. And if you leave them alone, that's what they should do. So 3-year-old boy not growing too well. This is the stuff that we'd like you to send in, because this is really, really short. You know, so you've got a kid who's growing all right till about a year and then just plummets right down. Tiny bit of bone age delay, but that's not constitutional delay in growth and development, because that growth velocity is just abysmal. And I also gave you that mum and dad giants way up here. So he should be up about, he should be 20 centimetres taller. And he's the one that we'd do measurements, we'd look at his birth weight, we'd look to see whether there's signs of growth hormone deficiency. We would do all these blood tests because he's so abnormal. He's not one we'd sit around. He's one that we'd also not just want to do a TSH on, because central hypothyroidism, you often have a normal TSH, and it's the T4 we need as well. So in this one, if we worked out that that was all normal, we would do growth hormone testing, and in New Zealand, a peak growth hormone greater than 5 is normal, and I'll show you what you do. And we tend to use 2 agents to stimulate that. There's a number of other things you can do. And hopefully got a slide, yeah. So what growth hormone does, it has little spikes at night and during the day. So if you've got a boy who wants to grow more, I usually tell him to go to bed. Make sure you're in bed by 9. Don't stay up late. You'll never grow, because if you don't sleep, you never grow. And then they realise I'm pulling their leg, because actually they're just short. So when you measure a random growth hormone, you're not likely going to get a peak greater than 5, are you? So the drugs we use, one stimulates sleep and another stimulates protein, which is how you stimulate. And that's why we do it. So if you did a drug test and they're all values around 1 or 2, you're growth hormone deficient. But over time, the amount of growth hormone you secrete from childhood is a lot less than you need in adulthood. And so you need a lot of growth hormone to actually have physical growth, but not much in adult life. And this is where adult growth hormone deficiency is such a problem, in that not many people need much. And if you had a tumour back here and you were on growth hormone for growth, you may not need it here. So you see that massive decline. So that's why if you measure growth hormone in middle-aged men, it is often low, because that's what it should be. We are lions in winters here. We're not meant to be virile out on the plains hunting. And that almost correlates with a famous slide on creativity in life, that you're extremely creative in childhood, and then you hit the teenage years, and then all declines, and then you get to this age and we get more creative again. I don't know if you've seen this slide. This is quite an interesting one, that we have a lot of ideas as kids, we write them down, and then we run out of them, and then a number of us start to get more creative when you're a bit older. So we did growth hormone testing on this kid, and this is just to say everything was less than 5. And then what do we do then? We say, well, have they got a tumour? Have they got a small pituitary? And I've just said, basically, no, this is just idiopathic. We didn't find the cause. So with that kid, if we put them on growth hormone, we would expect a massive catch-up, probably not even flattening off here. We'd expect them to keep coming up to that centile line. And in New Zealand, that would get funded, and they'd get funded to their final height. They'd get funded right to here. 1 or 2 more cases. So 14-year-old girl, she's short, she's not in puberty, and she's got puffy feet as a baby. This is one of the potpourri ones. This is a classic slide of a girl with Turner syndrome, who's 45X probably, so relatively short, and then slide off with growth at about 7 and don't go into puberty. And the puffy feet is because girls with puffy feet as a newborn are often got Turner syndrome. And this is a slide from the internet of twin sisters. This is a normal tall sister, and this is her sister with Turner syndrome, which shows you how much shorter they are. And they're also quite a bit more thick set. They've got quite stubby hands. They've got a bit of hypoteterism. And the common karyotype, and it's a simple karyotype test, is losing one of the X chromosomes. And if at 14 her LH is 50, she's also got primary ovarian failure, which most Turner girls would do with that karyotype, which is also why that girl in the vignette is very short. She needs puberty and she needs some growth hormone. There are other karyotypes. Why are they shorts too much for you guys? So if you leave a Turner girl alone and you even just do puberty without growth hormone, they end up being about 140, 145 centimetres tall. And we know with growth hormone we can push most of them up to around the 5-foot mark. And that's funded in New Zealand as well. And she needs puberty. In fact, if you talk to most Turner girls, the thing that really upsets them is the fact that no one put them into puberty when they needed to, and they waited till they were tall enough. And some of these girls are going to be very short anyhow. I'm going to leave the cases there. There's one more which I'm going to skip through, which is an inflammatory bowel disease. And I was going to go on to the little picture quiz for this and then go through the other one if that's all right. This is going to double up with the picture quiz, so we'll just ignore that one. Any thoughts on the growth disorder for Game of Thrones? He's got achondroplasia. He's a dwarf. He has a skeletal dysplasia. Which one's abnormal in this one? And this is from Different Strokes from the 1980s, because you all watched that when you came home from school. This little fella. He had chronic renal failure and recurrent doses of steroids for nephrotic syndrome, which caused him to be very, very, very short. James Bond, he's called
Jaws.
Jaws. And what's Jaws got? Why is his jaw so big? He's got acromegaly and gigantism from growth hormone excess. He's got this huge big jaw. He has got a huge big jaw. And he's got hypertelorism, huge big thick set eyes. So it's a combination of a pituitary tumour producing growth hormone, 1, before he's finished growing, which makes him tall, and 2, carrying on in adults, which makes him that thick set acromegalic look. NCIS LA, 7:30 to 8:30 Tuesday night. He's normal, she's gorgeous, he's Robin, and she's got Turner syndrome. And she's 4, maybe 4.5 foot tall at the most. She will be standing on a box in this show the whole way. And every time you see her photographed, they always show from behind and she's looking up. Yeah, she's a Turner syndrome woman, probably in her 60s now, so she wouldn't have had growth hormone. And him? Lionel Messi's story is that he was really short and they gave him growth hormone because he's growth hormone deficient, so that when he went to Barcelona he played better rugby. I just think he's a short normal who got growth hormone because they wanted to make him a little bit taller. But actually there's nothing wrong with him. In your case handout, there's a whole lot of stuff on puberty which I'll let you digest because it's all easy to read and informative. Okay? If you have any questions, let me know.